Hello and welcome back to Science of Medicine. I want to talk about some clinical applications of the endocrinology concepts that you hopefully have seen across the last few videos and show you how this is put into practice. Let's take a look at a 65-year-old patient that is complaining of increasing fatigue or feeling tired. And the person's physician orders some thyroid tests as shown. What's the most likely diagnosis based upon these test results? Well, I hope that you see that this person will have a primary hypothyroidism. And if you remember, the thyroid gland, which is making thyroxine, which will then have to do with the metabolic activity of cells, is under negative feedback from both the hypothalamus producing TRH and the anterior pituitary producing TSH. And so if you look at the free T4, which is the thyroxine, the unbound portion of that, it is low compared to that. That makes it a hypothyroid state. Now the question to distinguish between a primary, secondary, and tertiary depends upon the TSH and the TRH. In both cases, these are elevated. Since this is not enough free T4, the negative feedback will try to hypersecrete to make more of the thyroxine. And this is why those are both elevated. And so this is a problem with the thyroid gland, and therefore it is a primary hypothyroidism. All right, very good. Let's do another one that's even harder. An incidental CT scan, an image using x-rays of a 23-year-old female's abdomen reveals a tumor in her adrenal gland. Which of the following findings would be expected if the tumor involves hypersecretion of one of the native adrenal gland hormones? And you can have multiple correct answers. Would it be tachycardia, pubic hair growth near the belly button or the umbilicus, stria, hyperkalemia, darkening of the skin, or diarrhea from increased GI tract peristalsis? So pause this video, think this through, and then we'll step through. All right, I hope that you were able to get this very difficult question and answered tachycardia, pubic hair growth near the belly button, as well as stria. But the key elements here are that you have hypersecretion of one of the native adrenal gland hormones, and that this is in a female. So let's step through this. The first thing you need to remember is what are the hormones that are released by the adrenal gland? And so you have aldosterone, the cortisones, DHEA, and epinephrine and norepinephrine. So let's step through these and see what hypersecretion would do. So consider aldosterone. So if you have a deficiency of aldosterone, then you will have excess potassium in the blood, or hyperkalemia. So this hypersecretion is not consistent with a deficiency, which would lead to hyperkalemia. It does affect potassium because of aldosterone. It's just in the opposite direction. All right, let's look at the next one. Cortisol. Okay, the zona fasciculata makes the glucocorticoids. If I hypersecrete cortisol, what will happen? Well, if I have too much cortisol, then I can have stria. And if I have a deficiency, because I have a deficiency and I make this melanocyte stimulating hormone with the ACTH, I will get darkening of the skin. So in this case, the hypersecretion does lead to stria, but the darkening of the skin results from an underactive or hyposecretion of cortisol. So stria would be correct. Let's go down a little bit further. How about DHEA, the androgenic hormone? So if I hypersecrete, if I actually have too much androgen, then I will have androgenizing. This is a female, we're told. So one of the things that you would not anticipate from her would be to have the escutcheon of a male. That is, that the pubic hair would go up to the umbilicus. In fact, it should not do that. And so this is consistent with hypersecretion of DHEA. All right, we're almost there. What about the last set of hormones in the medulla? Well, epinephrine and norepinephrine will stimulate the sympathetic nervous system. And so if the sympathetic nervous system is stimulated, I can increase the heart rate. If the parasympathetic nervous system is activated, then I can stimulate peristalsis. And those are the two answers that you see. The correct one, hypersecretion of epinephrine leading to activation of the sympathetic nervous system, does lead to tachycardia, but it actually does not impact the parasympathetic nervous system. And so this hypersecretion of epinephrine or norepinephrine would not lead to increased peristalsis. It would inhibit the peristalsis. So I hope that now this makes sense in terms of why the tachycardia, pubic hair growth in a male escutcheon in this female, and stria would all be consistent findings for this tumor. Very good, very difficult question. Let's try another one. A patient has a 1.2 centimeter pituitary tumor of the corticotropic cells, leading to secretion of excess hormone. Which of the following manifestations is expected? Gynecomastia or breast enlargement, acromegaly, polyuria, moon phases, increased GI motility, or kidney stones. I hope you recognize that corticotropic cells are going to give you moon phases. So remember that corticotropes release ACTH, actually POMC, and that's cleaved into ACTH. And ACTH then stimulates the production of cortisol in the zona fasciculata. And the cortisol, if it's hypersecreted, will lead to moon phases. And so I hope you can see the stepwise manner by which you actually look at these possible answers and try to apply your knowledge to solve these problems. Great job. Let's try another one. Abilify, which is an antipsychotic drug, is used in many psychiatric disorders, and it blocks the D2 or dopamine receptor. Which of the following side effects is expected? Hypertension, galactorrhea, acromegaly, polyuria, moon phases, or darkening the skin. I hope you recognize that since it is impacting the dopamine receptors, it can lead to galactorrhea. You may remember that the dopamine will actually inhibit the secretion of prolactin. And because it inhibits prolactin, there's no prolactin made and there's no milk for females. However, if you block that receptor so that you don't get the signal to inhibit prolactin production, prolactin is made and you'll get galactorrhea. Let's try another one. Remember we talked about the steroid synthesis from cholesterol. Now consider a female patient who has a deficiency of 17-alpha-hydroxylase. Which of the following would you expect? Hypokalemia, polyuria, excessive sodium excretion, enlarged breasts, difficulty achieving orgasm, or a male escutcheon. So the first thing that you need to do is go onto this and see where the 17-alpha-hydroxylase is. And I hope that you can see it's over on the left-hand side, just under that step for going from pregnenolone to the hydroxy version of that, the 17-alpha-hydroxy hydroxy form. So as a result of that, you will tend to shunt things down the aldosterone pathway. And so if you block that 17-alpha-hydroxylase because you have a deficiency of it, then the only pathway available then to you to make this is going to make aldosterone. aldosterone is going to be made in excess, whereas other hormones are going to be deficient. And aldosterone excess will lead to hypokalemia, as we've talked about before. So these are a smattering of different applications, clinical applications, that you can use your knowledge of the endocrine system to solve. I hope this has been helpful for you as an introduction to endocrinology. As always, if you enjoy this Science of Medicine, please feel free to subscribe and to like or to leave comments in the comment section. Thank you very much, and I'll see you next time on Science of Medicine.